It's such a pleasure being here, and it's a great time, as you will see, to talk about myeloma, because it's not what the disease it used to be. It's not even disease what it used to be 3 years ago, as you will see. It's changed, and it's changing very fast. So it's a, I think, great message of hope with everyone here with myeloma or somebody in family with myeloma. So I'm going to cover a lot of area, and I'm going to speak slowly. So these are the disclosures. So when I say there is really great message of hope, it's because of the tremendous progress that has happened in myeloma. In last 20 years, there are 19 new drugs which have been approved for treatment of myeloma. Literally one new drug per year. And if you see here, the number of new drugs are increasing almost exponentially. So in 21 to 30, in next 7 to 10 years, we expect 15 more new drugs to become available. And this is not in research. This is commercially available, beginning to be available most of the places. They usually start to be approved in US first, but Europe is right together. And so this is the great progress. And because of this new drugs availability, the field is changing. We look at two things, what we call progression-free survival. And I'm going to try and make it not very technical. But progression-free survival is how long one treatment would work. It used to be 12 months to 18 months. Now it is 6 to 7 and more years. And that's for half of the people. Half of the people, the disease does not come back beyond 6, 7, and 10 years now. And people live very long. It used to be 2 years. Now it is more than 10, and I can't put the number because it is increasing by the day. So there's a great change in the field in how we treat myeloma. It's beginning to become a chronic disease. And there were 3 different eras in this progression. The first one was what we would call the transplant era. That was from 1980 to 2000. This is where transplant was main. It's still an important treatment. Then the second 20 years were what we would call targeted treatment. This is where bortezomib, lenalidomide, which most of you will be familiar with, became available in the research and in patients, and that has made the big change that it has made. And the current era is the immune therapy era, where you will see that there is absolutely a sea change in how the things have progressed in a good way. So these are the 3 different eras, and I've been fortunate to cover all 3 eras, starting with transplant era and now in the immunotherapy era. That also says my age. One of the important part of all this development is that when we treat patients with myeloma, what do we try to accomplish? Yes, the myeloma should disappear, and that was true till recently. But now the new technologies are helping us go even further. What we look for is minimal residual disease negativity, which would mean that when we look in the bone marrow, we may not find one myeloma cell in a million cells. It used to be 1 in 100, just 5 years ago. Now we can look for 1 in a million cells. And if it's not there, that's very good. That means it's almost gone, if not really gone. So this is what we try to achieve when we treat patients with myeloma now. And if we get there, and these are the curves here, and these curves, if it is higher, that's good. That means myeloma is not coming back. So you could see that anybody who is negative, they are in this group, where myeloma is not coming back. So we look for that. And even in newly diagnosed patients, when you start the treatment, or if myeloma comes back and we do second or the third treatment, in all of those settings, we try to now achieve MRD negativity. That does not mean that if you don't get MRD negativity, it's the end of the world. Many patients who are not getting there can do well as well. But we strive to get there. and it increases the survival, it increases the outcome of the patient. So this is our focus now with all the new treatment. Now, getting this MRD negativity also helps us in overcoming some of the risk. So you know there is something called high-risk myeloma and something called standard risk myeloma. Now, high-risk myeloma is when it comes back quicker. However, if we get this MRD negativity in high-risk patients, their myeloma does not come back as quickly. So now we know what to do, even if somebody has a high-risk myeloma, how to get them there. And that's something to keep in mind. Now, diagnosis of myeloma is a very straightforward thing now, and it used to be for quite some years, almost 50, 60 years. We do blood test and look for protein. We do bone marrow, which is painful a little bit, or more, depends on who does it and how is it done. But we look for myeloma cells in the bone marrow, and then finally take X-rays and look for this bone lesion. But now in 2020, we do a lot of additional thing as a part of the standard practice and sometimes part of the research. We do these free light chain measurements, we do FISH analysis or sequencing, and we do MRI or PET scan. PET scan is becoming more common. Either are similar in the value. So now when we diagnose myeloma patient, we do something more to understand it more, to be able to treat the disease better. Just give an example of PET scan. You could see that this individual's myeloma, all these black dots are myeloma lesions. It's many, many black dots. So it's all over multiple areas in the bone. And this is very clear diagnosis of myeloma. But when we treat this patient, and in very short time, in this particular case, it was a year and a half, patient got induction and transplant, and the dots are gone. And this is where we would get to when we treat patients with myeloma. And this is how PET scan helps us. Now, the thing about high-risk myeloma, it's a complex disease. Some patients have more changes, as you see here. Normally, it should be 2 of each, and you can see many more here. And what it means is that there are genomic changes in myeloma. They are not inherited, so you don't have to worry about whether my son or daughter will have it, but it's for the patient in myeloma there are changes. And we are beginning to define some of these. So some of these are considered higher risk myeloma. However, because of our treatment, some of the high risk is not so high risk anymore. So for example, if you get bortezomib, then this high risk because of T414 myeloma, and some of you may know this, is not as bad, meaning myeloma will not come as quickly because we use this drug. Similarly, we use lenalidomide, and it can also improve the outcome in these patients, but not in lesion 17p. So because of these advances in treatment, the definition of high risk changes. So if somebody is a T414 myeloma, it's not considered as high risk as it used to be. And that's a good news, because we are able to overcome this. And then I wouldn't tell you all the complicated thing about genomics, but we all, Fredrik and myself and others, we do bone marrow, and sometimes we take bone marrow, some of it for research. What we try to learn is what's really happening in myeloma at a very small genetic level, and then we can find drug that will work better. And this complicated figure here tells us that myeloma, when we diagnose, there are all these dots here. You can see these dots here. These are all the various mutations. And when myeloma comes back, it can become more complex. But the important thing is that some of these dots, this circle, small circle here that you may or, you could probably see, the dot inside is a target where we can use a new drug called BRAF inhibitor. So we can find new drug using some of these complex things. And because of so many change in myeloma, as you will see, there is this rise of immunotherapy, because there is nothing that can do better than our own immune system. Our immune system is trained to go and kill the enemy. enemy is myeloma. And so all this research tells us that immunotherapy would work very well. Now, this investigation I showed you is what we do today. But there are advances happening to make things easier. You know, anybody who has a bone marrow would surely agree that if I didn't have to do bone marrow, that would be better. So how can we do that? So there are diagnostic advances, and I will make it simple here, which is the new testing in the lab yet, not available in a commercial sense, but it will become available very soon, is where we can do what is called mass spectrometric measurement. And in this particular study, this newer mass spectrometry was compared with what we do right now, immunofixation. And basically what it tells is that when the older method cannot find the difference, the newer method can find the difference. The curves are separating, which means that the newer method is more sensitive. So then I don't have to go and do bone marrow. I can do this method till it becomes negative and then go for the bone marrow. So it helps us delay the need for bone marrow. The second new treatment and new diagnostic method is using the genome sequencing, but from the blood. So right now we do genome sequencing from the bone marrow. Again, to avoid the painful bone marrow, once we can find myeloma cells in the blood by very, very sensitive, sophisticated method, we may not need to do bone marrow as often, and we'll get information. So this particular line of research is progressing well, and it looks quite encouraging because in large number of patients, 84% of the patient, we can find myeloma cells in the blood. So that's a great future possible advancement. And finally, we take blood and look for genetic material in the blood itself, not in the cell, what we call circulating DNA. That's also a very new technology. One of my colleagues working in Boston published this and shows that if that DNA in the blood disappears, then it means myeloma is not there. And that is what we want to get it. And he can do this without frequent need for bone marrow. So there are a lot of good future diagnostic advances that are happening that's going to change how myeloma would be diagnosed, but more importantly, how we will follow. Because follow-up is where we need to do frequent bone marrows, and we can avoid that. Now to treatment. So there are a lot of advances in treatment.
So you have showed, which we also discussed with patients, that some are more high risk as a group, and some are more standard risk. But what does this information actually tell you with a particular patient? This patient has this and this cytogenetic, is considered high risk. Does that necessarily mean that they will have an aggressive disease? Can you say something about that?
Yeah, that's a very important point. So if somebody has features that we would call high risk, what does it mean? And what do we do? So in general, high risk does not mean that that particular patient will definitely progress quickly. These are all average when we take 100 patients. So high risk does not for one person mean that his myeloma is going to come back in 12 months or a year, 2 years or something. But what it tells us is that when we do the treatment, we need to be a little bit more aggressive. So we fine-tune our treatment to better control that high-risk disease. We might give longer treatment. We might give 2 drugs instead of 3, or 4 instead of 3, or 3 instead of 2. So our treatment is modified a little bit. And we might take more aggressive treatment earlier than going for longer. But I think if I understood the question right, not everyone with high-risk disease should think that his or her myeloma is going to come back very quickly. These are all averages.
Yeah, thank you. And I think also that even the fine-tuning is sometimes a bit complicated, because in most patients where you expect a good tolerance, if you're relatively fit, you would probably give the best treatment to both the standard risk and the high risk.
Correct.
And it doesn't really effect, but maybe it affects if you have a high-risk patient and the tolerance is, it's not bad, but it's not perfect. You might, in a standard risk, easier dose reduce, while in the high risk you maybe stay on and tolerate a bit more side effects, a bit more. Do you agree?
I think that is a perfect point. So one point Dr. Schjesvold made was that high risk or the standard rate does not mean we give less. We give, if we can, we give 4-drug regimen to both now. We used to be a little bit choosy, but now, so do the same thing for both. But if it's high risk, I would try to keep the dose and or number of drugs on a little bit longer, versus would be more inclined to change the dose if it is standard risk. And I think that's a very important point, that right now we want to cure everybody, high risk and standard risk. And so doing less in one is not the right option. We do the best for everybody, but then depending upon the tolerance, side effects, we can change the dose a little bit more liberally for standard risk, a little more conservatively for the high risk.
And just before we move on, now you covered diagnostics. So are there any questions regarding, noen som har noen spørsmål om diagnostikk og sånn før han går videre på behandling? Så det er lov å komme med det nå.
På norsk?
Som du vil.
Klarer du det?
Ja, det går bra.
Jeg sitter og tenker på high risk, altså på hvilket stadium i hele sykdomsforløpet, eller livsforløpet da, fra du får første diagnose. Snakker vi her om tidlig stadium, eller er det ved tilbakefall og utover? Hvor er vi igjen?
Ja. So the question is quite interesting, actually. He asks, high risk, are you talking at diagnosis or at later, or can this develop and change in a patient?
That is a very, very astute question. So in our understanding the disease, our ideas about high-risk definition has evolved to exactly what you're asking. Now the definition for high risk is at any time point, because we know, as you said, the risk changes. So based on our ability to detect all these changes, somebody who could be standard risk at the beginning can become more obvious high risk at the relapse. And so the risk can change, and that's why what we now advocate to all our physician colleagues is to repeat the risk stratification every time there is a bone marrow, because there can be change. One treatment can kill all the good cells, but the high-risk cells may come back, and now it's more obvious. So to answer to your question, the risk stratification can change, and that's why we need to repeat it periodically if myeloma comes back or when it comes back, because it can change. But that's a very good question.
And I can also add to that even though we can do lots of analysis, as they say in the UK, the proof is in the pudding. So you can have a patient that doesn't have any high-risk markers, but the disease behaves aggressively. There's just so much we know as of today. So there's no, you can be a high-risk patient and it behaves not that bad, and it can be nothing, no markers, and it can still behave very aggressively. So to follow the disease is just as important as the tests.
So that's also a very important point. So, and that's why, as Fredrik said, we treat everybody with the best treatment we have. And the reason is that we only know what we know. And there are a lot of things we don't know yet. We might try and claim we know, but we don't know a lot. So there are patients who do not have traditional high risk, but their myeloma behaves more aggressively. And we have a really focused study at our center where we have 200 patients whose disease came back very quickly, but they do not have any traditional marker. So that's where we would try and learn what did we miss, what is that we don't know. But to a very correct point, there are patients who may not have a high risk, and they may behave like that. And on the other hand, there are patients with high risk. I have a patient who is 17P, and she is doing well for the last 15 years. So high risk does not always mean it may come back. There's something else in that patient that's making it behave not high risk.
And just to say that it was not the intention to compare patients to puddings. Maybe some of them.
Okay, so now we move on to therapy, which is where the real pudding is. So there are super advances, and 3-drug regimen that you may all be very familiar with, combination like the standard combination like bortezomib, dexamethasone, and lenalidomide. I mean, dexamethasone, we know it's a simple drug, but it's complicated drug, causes problem. And usually when patients get dexamethasone and we ask patient, how are you doing? Patient usually says, I'm doing fine. But if you ask family or the spouse and they said, oh my God, there's a problem. So simple drug, it works well. That's why we still use it. But those are the standard combination, 3-drug. But now we are advancing to 4-drug combination, where we add daratumumab or isatuximab, one of the two antibodies, with the same other 3-drug. And the 4-drug regimens are beginning to become more standard, more common. And why is that? Is because of the studies that have been done. So, for example, this particular study, it's called Cassiopeia study, where daratumumab, the antibody, was combined with Velcade, thalidomide, and dexamethasone. This was the combination that was standard in the region where the study was done. And the bottom line is that these 4 drugs give much better responses. They give much higher responses. You can compare this versus this. They give much deeper responses and more frequent MRD negativity. So because of that, now the 4-drug appears to be more attractive option. And patients who get 4-drug, they do better than those who got 3-drug. And this is in the beginning. So now we are beginning to do this kind of studies. Initially, a year or two ago, 4-drug were reserved for high risk and 3 for non-high risk. Over a year or so or two, now we are switching everybody. As Fredrik very rightly says, everybody needs to do better. And so we begin to use those when feasible. Not everybody needs it, everybody gets it, but that is where we are moving towards.
Just to emphasize, this is younger patients before transplant, right?
Correct, correct, very much so. So these are all studies where transplant is part of the treatment plan. So these are younger patients, and younger is very variable definition. It changes by the country, it changes by the person. Younger is your age, and young and less is younger. In US it's 70, in France it's 65, in many centers it's 75. But I don't know what the number is here, if there is a number.
No, it's a general number of 70. So below 70, most get transplant,
yeah.
And above 70, some get transplant.
Same as in US, exactly same as in US. So beginning to be using 4-drug. And there is another very good study that came out of our center, where we combined daratumumab with Velcade, lenalidomide, and Dex. And this study showed that close to 40% of the patient will become MRD negative. That's our target, MRD negative. So we are beginning to do very well. And those who get this 4-drug, they are also having disease not come back quickly. This is one of the still newer study, but we do know that 45% patients who are MRD negative, their myeloma is not coming. So these are the data that then drives to what we do in our practice. Similarly, there is another drug called carfilzomib, which can also in some countries be used in newly diagnosed setting. And this particular study shows that if you are MRD negative for 2 times, 3 to 6 months apart, usually 6 months in this case, then at some point you can begin to hold the treatment. It's a very small study. We have not adopted, none of us have universally adopted this yet. But just to give the idea about future, based on this kind of study, someday we can decide that can we stop the myeloma treatment and give patients a free time without treatment, without toxicity? And so this is one of the studies that is beginning to give idea how can we decide when to stop treatment. We had a discussion in our physician group yesterday. Can we stop, or do we have to continue forever? And the good news is that maybe this kind of studies will tell us when we can stop the myeloma treatment. So there's great hope there. So there is a list of, and this is a busy slide. I don't want you to look at all the numbers there. I'll tell you where to look. So these are all various 4-drug regimens done by all various investigators all around the world. Basically, it shows that this treatment works almost 95 to 99% of the time. It's such a good time when I can see a patient and almost tell that 100% you're going to respond. And I remember 30 years ago where I couldn't even say half of them would respond. And now be able to say that you are going to respond, your myeloma is going to go away with the treatment I will start. So it's such a great feeling and the time to be in that. It's good for patients to know you can see the smile on their face. And 80% of the patient, it goes into complete remission. 30 to 50% becomes MRD negative. So this is the progress that we are going towards. Now, these 4-drug regimens are very important for high-risk patients. That's where the study started initially. So this was one of the French study, where they gave the induction, did the transplant, gave the maintenance. And doing that, they show that a large number of patients, 60% patients, myeloma was 0, and it has been sustained. Of course, almost everybody, 96% responded. So this was in high risk, where we want to get best response we can get, and it's 60%. This was a French study. A similar study done in, I think the slide is missing in the middle, done in Germany showed similar results. 66% patients became MRD negative. So I think even for high risk, we are doing much better than what we used to. One thing you have to remember, this survival numbers that you see, 10 years, that what it means is that the patients got those treatment 10 years ago. 10 years is like old days in myeloma, dark days in myeloma. That's very different. So what patients get today, they're going to do much better than the number I tell you, because the old treatment was so good, the new treatment would be even better. So then we move on to the role of transplant. We are doing so well with all this standard treatment. Do we need transplant? So we did a study to look for that question, that if you get these 3 drugs or 4 drugs, in this case was 3 drugs, that gives 100% response, what does transplant do? So just to make it simple, this is half of the patient in this study, 350 patients, they got just the standard treatment, RVD. And other half got RVD, but they also got transplant. The question is, those who got transplant, are they doing better? And the answer is that people who got transplant, their myeloma came back later than those who did not get transplant, 46 versus 67 months. So big difference. And it also showed, if you look at the graph, these are the group of patients who got transplanted. And the graph higher up means that myeloma did not come back quickly. The blue is without transplant, it came back quickly, or quicker than the other group. However, the good news is that when these patients, we followed them for 8 years, the curves are very overlapping. It means that if the patients got transplant early, or some of them got it later, their overall outcome is same. So the new treatment are making myeloma remain away for much longer time, similar to with or without transplant. So how we do transplant, when we do transplant, all becomes an important discussion with the physician. We still do transplant as one of the standard treatment. In our centers, in the US in general, I'm sure here it is similar practice, that it provides a good, deep response. Now, one of the things we have learned while doing transplant is also that when myeloma comes back after transplant, it may have some features which makes it more immunogenic. So immunotherapy might have some good effect. So there are benefits, and this was a very complex genomic study we did at our center. Mehmet Samur did this study. But he showed that when myeloma comes back, there are new antigens which can be good immune target. And so we are studying that to see what are the other good effects of transplant in this patient population. Now, the second component or group of patients are those who are not eligible for transplant for very many reasons. It could be age, could be other diseases, could be preference. I don't want transplant. There are still patients who just don't want it for various reasons. So what are the options there? And even for those patients, the options are 3-drug regimen, which works very well. One of the top 3-drug regimen is what is called Dara Revlimid Dex, DRD, and I'll show you data on that. The other top candidate is what we call RVD light, little bit lesser dose in this patient. The difference between what we do in transplant eligible versus ineligible is we decrease the dose a little so the toxicities are less, and also give it little less frequently in the regimen. And if you look at the two of this very good combination, one is the DRD, Dara Revlimid Dex, and you can see patients who got those 3 drugs have a significantly better outcome 62 months before myeloma came back, even though they didn't have transplant or anything, 5+ years. And they all are living longer in general. This is RVD Light was a combination that was developed in our center, and it also provides equally good benefit. So these 3-drug regimens are really very good options for this patient. For the patients who are beyond 70, they're not going to go for transplant. One can also try the 4-drug regimen. We quite often beginning to do that because 75 is not old. In my book, in any of the books. When I see patients who is less than 80, I would call them relatively young. Beyond 80 to 90, maybe middle age. After 90, we can discuss. So I think that is the right definition.
Did you say that 10 years ago?
That number changes. So point is that decision about the type of treatment would be based on patient's physical health, physical age, not numeric age. Number doesn't matter. So that would be quite individualized. I mean, and I'll talk about how we have done transplant. The oldest patient in my old days, we don't do it anymore because we have so many options. But when we didn't have any of this newer option in 90s, the oldest patient I transplanted was 84, and he sailed through without a problem. I wouldn't do it today because I have so many good choices. But the point is it can be safely done if all the features are in the right direction and the options are if that is the best option. Another thing that one of the research studies showed that we have what is called frailty score, how frail a person is. And when we call somebody is moderate to severely frail, they are really not very mobile, they have a lot of issues, age-related, but also other illnesses, cardiac problem or other problem. And this study basically showed that when patients who are even moderate to severely frail, if they get 3-drug regimen, they do better than the 2-drug. In the old days, our intuitive thinking was that if somebody is on the older side, by whatever definition, but more physically, let's give 2-drug, and then see how he or she does, and then if it doesn't work well, I'll do 3. What this study shows that even in those patients, carefully planned, 3-drug regimen might provide better benefit, and their frailty will decrease. They will become more stronger. So I think we are beginning to do that irrespective of age, we can modulate our treatment. So that's about the newly diagnosed patients so far, how we start treatment, how we give the transplant as a consolidation. And what I'm not mentioning much here, but happy to answer question, is that we have a practice of having long maintenance treatment. Now, maintenance treatment usually ends up getting lenalidomide, and it's given for 2 years or longer, but would depend on patient's tolerance. We are doing studies to see when can we stop. More than 1 year is better, but not necessarily forever because it can affect quality of life. And what is becoming very important, and I'm sure Fredrik will make the same point, is that in myeloma, extending the life is not an issue. Patients would live well and long. What is becoming important is the quality of life. And because of that, the maintenance treatment can be modified.
Yes, I just thought that jeg tenkte at det var et tidspunkt nå, ferdig med nydiagnostisert behandling. Hvis noen har noen spørsmål om det, så kan vi ta det nå før vi går videre på tilbakefall.
Thank you for the interesting news. I was just thinking about one thing. For me, personally, it's like survival is one thing, but as you mentioned at the end now, life quality is, for me, much more important. And I was thinking, like, if you use 3 treatments compared to 4 treatments, won't the side effects be much higher in general?
Is it 3 drug versus 4 drug, or?
Yeah, it's just the quality of life will increase into quadruplets. And, yeah.
So that's an important question, whether the 4 drug has more side effects versus 3 drug. In general, without being specific, when you add a drug, there is always a possibility of adding the side effects. It's a theory. However, the drug we are adding here, for example, is daratumumab. It's an antibody, which has less significant side effects. So the quality of life does not get affected very tremendously. And because it works quickly, it can also make patients feel better quicker. However, daratumumab is a weekly injection in the beginning. So you have to go to hospital every week. Does that affect your quality of life, that you have to go to hospital once a week? Probably not, then it's good. But otherwise, that can affect your day-to-day activity. Quality of life, what I would also say is that you are able to continue your normal life. If you are working, you can go to work in the morning, come back in the evening, etc. So any interruption, I would take it as partly affecting the quality of life. But if that's not an issue, then that's a great thing. The second thing is the side effects for this 3rd drug. We look at blood counts, which we monitor. Usually, patients won't get affected too much. It can have some immune effect, but we give you something to control. So in general, 3 versus 4 drug, when patients ask me the same question when we talk about it, I would say it doesn't get significantly affected, that I would be worried about that to decide 3 drug.
Så noen andre spørsmål til førstelinjebehandling? Okay, move on.
Okay.
Yeah.
So patients get all this treatment, but in some patients, I don't think all patients, and we can discuss in the end, I think there are patients whose myeloma is not coming back anymore, and definitely not coming back in a short period of time. 40% of the patient in one of our study, myeloma hasn't come back for 10 years and more. So, but eventually, if it comes back, then we have to decide what is my next line of treatment? What's my next treatment? And how do we make that decision? What do we decide? What factors do we look at to decide the next line of treatment? And the reason it has become complicated is because all the choices we have. As I showed you, there are 19 new drugs. We only use 3 or 4 drugs in the first line. So we still have 15 drugs to choose from. That decision is made based on various factors. And that ends up being physicians' decision-making. This is where the AI, ChatGPT, is not going to help yet. I think you have to go to the doctors and see one of us, and then I can judge how you're doing and what could be the best next treatment. So one of the things we look at is frailty. Patient's age, performance status, how mobile the patient is, the disabilities, comorbidities, cardiac issue or not. That's one group of factors. The second is, what has the disease caused to the patient? The kidney function. Quite often, myeloma is connected with kidney disease. If kidneys are not totally normal, then I would use certain drugs, and if they're normal, I would use certain drugs. So that goes into that equation. And then bone disease. It's important to keep that in mind because that gives the pain and the symptoms that needs to be controlled. And then how aggressive the myeloma, high risk versus not high risk, how would I manage? Lifestyle, quite importantly, patient's preference. I want to get oral drug versus IV drug. If one is better than other, usually there is no discussion. Everyone wants the best. But if they're two equal decisions, one can discuss. And then travel. Sometimes you live in an area which is quite remote. And then certain treatment may not be easily administered in a more remote area. True here, for sure. I was in Tromsø, and I know if I go further north, it may not be easily accessible. The good news is there are good drugs that can be given less frequently. So even if you are in a remote area, it can be administered. Same thing goes sometimes in the US as well. It's a big country, and there are remote areas where patients can't drive 2 hours every week to get something, and we have to modify. So I can very much relate to some of the problems one would face here. So keeping all those things, but most importantly, the treatment history. What treatment did the patient get in the first line determines what I give next in a large way. Because I would try to use a little bit different drugs than what I used first time, because myeloma, having seen those drugs, might not have a great response to some of them. The good news is that quite often we can go back to the old drug, the one which patient has received, and still use it quite effectively. So this is a big laundry list. I don't want you to go through each of them, but we have many standard combinations using drugs like carfilzomib, pomalidomide, ilotuzumab, and the antibodies that may or may not have been given, daratumumab or isatuximab, in some combination. The important point is here, where it shows that these drugs work very well, and even in relapse patient, combination of 3 drugs works better than 2 drugs. So these are all various studies that all of us have been part of, and you are very fortunate. Fredrik has literally the state-of-the-art studies all available here. So those studies are very important. And just to give a point, I do studies for living in my institution, same thing here. And one thing important is that almost always, the study, if you go on a study, whether it is 2 drug versus 3 drug, the study is only done if the control arm is the current best treatment. And then you get the test arm, which is something which we think is better, but we don't know. So if you go on a study, you will never get something inferior. You will get something standard, or what we think is better, but we don't know it. And that's why you do the study. So this is how the studies were done, 3 drug versus 2 drug. And you can see that when you get 3 drug in this one case, 80% response versus 66%. So now 3 drug is better, we use those. So the summary of this slide is that almost all studies in relapse patients shows that getting 3 drugs, whatever the right combination for you, based on all the features I showed, will be the way to go as a second line. Now, one example for here, when carfilzomib and daratumumab are combined, you could see that when you get the 3 drug, patients do so much better, 15 months here versus 28 months. So 15 versus 28. One would have myeloma not come back for almost double the time when they get 3 drug. Again, this particular combination may or may not be right for you today. It could be right some other time, and there are many factors that goes there. One more additional thing about what else is new. And there are 2 new similar drugs that are going to become available probably in next 1 to 2 years. One of these drugs is mezigdomide, and the other drug is called iberdomide. Both are cousins of each other. They are very similar to lenalidomide or Revlimid and pomalidomide or Pomalyst. They're cousins of it, but they're a better version, less toxic, more effective. So stay tuned to get this become commercially available because it shows responses when a lot of other treatments have failed. So you could see, just with one drug, 40% patient responded when it was given as the fifth-line treatment. So very, very exciting. And again, in combination with other drug, it gives 80 and 90% response rates. So really, the future for this drug or this class of drug is going to be very important. But now we come to a very important new area of the great excitement, which is the real immunotherapy. What you may know as CAR T-cell and what you may know as bispecific antibodies. Now, the target for that, the primary first target for that is something called BCMA. Now, BCMA is present on myeloma cell, but almost nothing else in the body. That's why it's a good target, because when we give something that goes to BCMA, it's going to only impact myeloma cell, which are shown here, maybe a little normal plasma cell, but nothing else in the body has that on the surface to a large extent. So we do not get much toxicity. It leads to only myeloma cell killing. And number two, this particular target, myeloma cell requires it for its continued growth. So when we treat, this target doesn't disappear, because if the target disappears, myeloma cell may not survive either. So it's a very good target, and that's why we have so many new drugs all going after the same target in different ways. So one of the first CAR T study done was this KarMMa-1 study, and the CAR T product is called ide-cel. Now, to describe CAR T, and I do not have a cartoon here, I think, or I think it's hidden here, but it is what we call cellular therapy. From blood, we take patients' T cells or immune cell. In the lab, it is modified to acquire certain characteristics so that it can now, when we give it back, it can seek the myeloma cell, bind to it, and kill it. And in the process, it grows further. So it is like a missile, targeted missile, programmed to kill myeloma cell. And the technology is very standardized now. So using this treatment in very advanced myeloma patients. So in these patients, they had received on an average 6 different lines of treatment. So if you look 3-drug regimen, they got 6 of those before they went on this study. So this is where if we do the standard treatment, only 20% patients will respond, and the response will be for 3 to 4 months. This is what used to happen 4 years ago. With this treatment, with the standard dose here, the response rate was 81%. So instead of 20%, now it's 80%. And in the patients who got the right dose, the myeloma did not come back for 12 months or more in more than half of the patient. And the overall survival was, which would be 6 to 8 months, now was more than 24 months. So this is one CAR T cell. The second CAR T cell is called cilta-cel. And that's probably going to become available here, I think. That is 98% response. Everybody responds to this, even as the 6th line treatment. So really very, very exciting. The response lasts very long, 36 months. So what would be 3 months, now is 36 months. And more than 60% patients are living well beyond 3 years, which would be otherwise 6 to 9 months. So this treatment has really revolutionized what we can do in even late stages of myeloma patient. And not only it works well, but it can be given at any age group. In transplant, we said 70 is our cutoff. Younger than 70, we do it. Older than 70, maybe not. Here, the age limits are changed quite dramatically. Just recently, last week, we had a patient, one of my patients, 81-year-old, got CAR-3, sailed through, did very well. In fact, when I saw her, she looked 10 years younger. And so it is, the age limit has gone, and even patients who are more than 70, this group, they have a very good response, 90% compared to 65 was 84%. So they do equally well, and they do not have excess toxicity. So I think that is something to keep in mind about this new treatment. Now, I don't know. Yeah. And this treatment not only works, but it also leads to significant improvement in the quality of life because patients do well. So you could see that the PET scan I showed, within just 1 month of getting CAR T cell, this was all the dots here, they all disappeared. So the bone-related issues became better. And especially for in this country, where there is passion for snow-related activities, this was one of my patients who sent this picture around 4.5 months after getting CAR T cell. 4.5 months when she got CAR T cell, she was reasonably, I wouldn't say bedridden, but quite not disposed to much activity. 4.5 months later, she sends me this picture. So it improves the quality of life. I wouldn't advise everybody to do it. You want to talk to your physician if it is safe to do it, etc. But the point is that patients may do well enough to go back to quite a good life. And I thought this was very apt for all of you in Norway, where skiing is the passion. Now, because it works so well at a later stage, we are now beginning to see how we can do it earlier. And so there are 2 studies done where it was given as a second line or third line. And it clearly shows that in patients who get it early, the line here or line here, they are doing much better than those who get standard treatment for that particular stage. So now we are all hoping that the CAR T can become approved for earlier line of treatment, because one of the important points about CAR T is that it can get much higher level of MRD negativity. Many more patients will become MRD negative. Now, as the question was whether the 4 drugs would cause more toxicity or not, the question what a treatment like this would be, what's the toxicity? How dangerous it is, or how it affects patients' life. So these are some of the studies that we have done. These are the 2 products that I talked about, these 2. But there are many more in pipeline studies and other drugs. I'm only going showing just select example. Now there are 3 main toxicities of this CAR T cell. One is the cytokine release syndrome. The second one is some sort of neurotoxicity. And the third one that we are more careful with is infections, blood counts and infection. Now, some of this toxicity happens very frequently, happens in 90% of the patient. Why does that happen? It's because when you get CAR T cell, it absolutely close to 100% kills myeloma cell. And in the process, the CAR T cells grows. It grows because it knows it has more myeloma cells to kill. And it happens very quickly. It happens in 2-3 days. And because of that, it overwhelms our body, so much growth. And that's one of the side effects that you see, we call CRS. 6-7 years ago, when we started doing this, it was new, novel, and something we were very careful with. 7 years later, the management of CRS has become very standard. It's, I would say, safe, and we know what to do. It's very standardized. And nobody should die from CRS. Nobody does die from CRS. So the toxicity is not as troublesome as worrying. And it invariably is what we call low grade, grade 1 or 2. Only 3 to 5% patients get grade 3, and that too, we are beginning to know how to prevent that higher grade. And there are treatments for it that we can now give very early and mitigate it. The second toxicity is neurotoxicity, again infrequent, only 15%, and almost most of them are low grade. So we can give again, the same drug or steroid and take care of it. So not a major side effect anymore. The side effect that we are very careful and we are very proactive is to prevent infection, because CAR T cell for a certain period of time can affect your immune system. We know what to do, but we have to do it, we have to follow. It requires you to get some prophylactic antibiotics, also get what we call IVIG injections once a month or thereabout. So we can prevent it. And with this, the toxicity profile is not so bad. And to give quote from some of our patients, and most of the patients initially had transplant, and then when 5, 7, 10 years later, myeloma, if it did come back, they got CAR T. And I asked all of my patients, how do you compare your transplant, which they got at a younger age, than your CAR T? And almost 100% tell that CAR T was much simpler and easier. So it's not a very difficult treatment. It requires setup, it requires expert handling, but it can be safely done. Now, question comes about cost. And in this great country, I think unlike where I come from, it is actually, in US, not everybody can get CAR T because of insurance coverage, this and that, and the government may or may not take care of it, although it's pretty good in general because how effective it is. But question of cost always comes up. In general, for regulators, so for government or for insurance. And it so happens that there are analyses done about cost. And based on the benefit it gives, it looks like that it is not, it's quite cost effective because the responses are super good, they last long enough, and very importantly, what we say in CAR T or patients say in CAR T is that it's one and done. You get CAR T treatment, and till myeloma comes back, there is no other treatment. There is no maintenance, there is no other treatment given for myeloma. So the toxicity is not there, the quality of life is very good because you're not taking anything except some prophylaxis. And so because of that, in a 3 to 5 years time frame, it becomes quite cost effective for whoever pays for it. And there are numbers that are given out, there are complicated calculations of how much does it cost. So for CAR T, one of the calculations was $112,000, but a similar treatment, we talked about this DRD treatment, it's $150,000, and there is another selinexor, Velcade Dex, it's $400,000. So compared to standard treatment, which works for shorter period, this works for long period and well. So initial number might sound very high. I think in a longer run for government and others, it's going to be more affordable treatment. So I'm hopeful it will become accessible more widely. There is a catch there that the production, there could be limits with the company. They cannot make it yet in an unlimited number. So we have to be a little bit careful there. Then there is a second treatment, new treatment called bispecific antibodies. Yeah.
Such a big topic. So I think if you want to have questions, eller hvis dere vil spørre noe om CAR T, så kan man jo gjøre det nå. Så det noen som har noen spørsmål om CAR T-behandling? Bare vent litt, vi tar det med mikrofonen.
Yeah, thank you. Sound? Yeah, you can hear me? Just a specific question about CAR T. Can it be done repeatedly as well? Or is it like other treatments that it's a one-off and then the cancer becomes... And a more general question related to immunotherapies is, from my understanding, a problem with multiple myeloma is that you can have different cancer cells in your body at the same time, and treatments work on one of them and perhaps not on others. So I wonder to what extent immunotherapy goes beyond that problem, or if it's still a problem in the case of immunotherapy.
So the first question is, can we do CAR T cell treatment multiple times? And the answer is yes. One of the target I showed is BCMA. We already have CAR T against another target called GPRC5D that we already done phase 1 and 2 study. We are now beginning to do larger study. And we have given, in our research, patients who have had one CAR T followed by this other new CAR T cell. It still works quite well because of the different target, etc. And so the answer is yes, it can be done and has been done. We have already done it. The second question is...
Nikhil, what about giving the same CAR T again?
So we have done that too, that we have given one CAR T. When patient came back with the disease after whatever time frame, we have used the second CAR T, second time, either the same CAR T cell or the same target, another CAR T cell. So patient has got an IDUS cell, they could get CARVYKTI, or they got IDUS cell, they got IDUS cell again. So when we give the same CAR T again, the responses are much lower. They're around 25–30%. It still has worked. We have given higher dose, etc. The companies are not evaluating it too much, although I still think there will be some role in using the same one again. But we have given the other CAR T cell, and it has also provided benefit. So when we can try the same CAR T cell, usually when the companies make CAR T cell, they make enough for more than one infusion. And because it is so new, they have not yet standardized. But there is always enough for a second one that sort of belongs to patient and can be considered in future as a second infusion. So the answer is yes, same BCMA works, but less, around 30% or so. The non-overlapping BCMA followed by GPRC5D, that is a very good response rate, 70+% response rate in our smaller studies at the moment. And the good news is there are multiple new targets that we are all evaluating in our lab to go to the second, third, and fourth target. So that's one part of the answer. The second question was also a very scientifically good question, which is that if you go after one target, then you may develop resistance, and then the second target. So one of the studies that I'm not going to show here because it's a very new early study, where this bispecific from two different targets were combined and given together, and it ended up being more significantly positive. And so there is something, and so we are all developing CAR T cells that targets two different molecules and combine it in one to get better effect, longer effect. And so those are all very early studies showing promise. The reason it is a little slower is that the single targeting CAR T cell, especially BCMA, which is an important target, is so very effective that the need and urgency to do multiple has been a little bit less, and the focus has been more to make this one even more effective by itself. But there are all sorts of good studies going on to target multiple antigens at the same time.
But I can also comment that CAR Ts are now, the studies that has been done and are approved drugs in Europe and US, they are in late line. Mm-hmm. And even though they are very efficacious, they don't kill all the cells, or as far as we know, not in many patients. Mm-hmm. So there are always some cells surviving.
Correct.
And that's so for that matter, CAR T is like any other drug. It's just better, and there are fewer surviving cells, but they're still there. But maybe different when we put this into first line, right? Yeah.
So when you go early, there is less chance of resistance, few cells surviving, and we may get better results. So the reason we are moving early on is that there may be easier target to kill almost all, if not all.
Yeah, I didn't get all the side effects. I just saw the infections, but what does the other things means with CAR T cells?
Yeah, so maybe I can take that question in Norwegian. Yeah. Så hovedproblemet med CAR T i starten tenkte vi da var dette som vi kaller CRS, som på en måte en akutt reaksjon, som som å få en blodforgiftning, du blir dårlig syk som av en influensa og sånn. Det som han sa, ikke noe farlig lenger. Vi vet hvordan vi skal håndtere det. Det kommer på et ganske forutsigbart tidspunkt. Du ligger på sykehus, dette håndterer vi veldig bra. Og så det noe som mye mindre vanlig, og det nevrologiske bivirkninger. Og det mye mindre vanlig, men litt vanskeligere. Og det kan være sånn at man framstår litt nesten dement, at man ikke responderer helt på det du blir fortalt, og det starter kanskje med at det er litt vanskelig å svare på enkle spørsmål, og så kan det bli verre. Dette er uvanlig, og vi har behandling, men det er ikke alltid det går helt over med en gang. Ikke et stort problem, men et større problem enn det første. Det tredje som vi har sett er at siltacell, den som heter Carvicti eller siltacell, den ene av disse, den nummer 2, den kan gi litt sånn, også nevrologisk, litt sånn Parkinson-aktige symptomer, også et veldig fåtall av pasientene, og det kan også vare en stund. Så dette er ikke uproblematiske medikamenter. Og så er det siste som er infeksjoner. Det er relativt vanlig, men det er vi stort sett i stand til å håndtere på en måte. Så alt i alt en veldig god behandling, men den har sine greier da. Og så er det ting sånn som disse nevrologiske tingene kanskje mer akseptabelt når du har ingen alternativer, enn når du skal ha det ved en diagnose, når du egentlig har en ganske god prognose uansett. Bedre med dette, men det kommer med noen problemer, så man skal være klar over at dette ikke det kan være en pris å betale av og til også for pasienter her. Ok? Det aller meste jeg snakker om nå, dette er jo litt nytt da. Det går over, men man har sett sånne Parkinson-aktige symptomer som har vart i 6, 7, 8 måneder, men det ser ut som de går over til slutt. Ja. Har du noen flere spørsmål til KRT?
One more question. I have a question about plasma cell leukemia. Can you use the same drugs, drugs for plasma cell leukemia that for normal multiple myeloma?
So plasma cell leukemia also has the same target, BCMA. And we have, usually in the beginning of the studies, we do not include plasma cell leukemia patients for various reasons. But now in our clinical practice, we have treated patients with circulating plasma cells, and they respond quite well. And usually we try to decrease myeloma before we give it so that it's better tolerated. But even with circulating cell, we have treated patients quite successfully and quite well.
Jeg lurer på om disse nye behandlingene som du presenterer nå, og som du skal presentere, er alle de tilgjengelige i Norge?
She's asking about the availability in Norway. Så det korte svaret er nei. Per i dag er ingen tilgjengelig bortsett fra i kliniske studier. Vi har hatt en liten periode nå der et av de medikamentene skal snakke om, talketamab, har vært tilgjengelig på sånn compassionate use gratis medikament, men den perioden går over. Den startet for ikke så lenge siden, og den går over i løpet av en måneds tid. Så det er veldig kort vindu. Det er litt tilfeldig å treffe det. Og da skal du ha prøvd absolutt alt annet som finnes. Nå skal siltacell, den ene KRT-en, skal vurderes av beslutningsforum i løpet av høsten, og teklistamab, den ene bispesifikke som kommer her, skal vurderes igjen i januar. Så vi håper jo på at det skal bli tilgjengelig. Når det gjelder bispesifikke, det er medikamenter fra apoteket, sånn at hvis vi får det godkjent, så kan vi bare bruke de. Mens KRT er et begrenset antall vi får. Dette er slotter, som det heter, der de gir Norge 15 i året, sannsynligvis første året, hvis det blir godkjent. Så det vil si at et ganske fåtall av pasienter vil få det, og det vil være en sånn nasjonalt gruppe som må da bestemme hvem som skal få det. Og da vil man har vi ikke bestemt hvordan det skal gjøres, men vi har noen tanker om det. Og en ting er at de som har de aller mest aggressive sykdommene, de har ikke så god effekt av dette heller, og vil ikke da bli prioritert til en av få plasser da. Men dette kommer til å være vanskelig, så vi må lage klare regler for hvordan man skal prioritere dette, så vil det være en nasjonal gruppe som bestemmer det da.
You said siltacell would be available.
Pardon?
You said that siltacell would become available.
We hope that it will come available this fall. Yeah.
Due to the heterogeneous nature of the disease, Is there any thoughts about targeting more than one target in the CAR-T? Because I think the CAR-Ts are only targeting one target at a time.
Can you tell me?
I just ask if there are, since there is heterogeneity, whether we are making CAR-T cells that attack several targets at the same time.
Yeah, so there are multiple research in that area. One is much simpler, which is we take two right now, but more than two eventually. CAR-T cell produced separately, put it together and give it. So each CAR-T cell going after one target, but in the infusion, there are more than one type of CAR-T. That's one. And the second more interesting is where we have the same cell expressing two or more, right now it's two, target at the same time. And there is also something where we need both the target versus one target to make it less toxic. So there is all very good research ongoing to go after more than one target. Usually two would be more than enough, probably three will be maximum we need to cover the heterogeneity, because BCMA is expressed on almost every cell to start with, almost. And that to remove that almost, we have a second target. So I think two targeted CAR-T cells are already in early part of our research, and they should move forward quite quickly. The problem we have to be careful is that when we add target, we have to worry about toxicity. We are adding something. So how to decide whether we give one target treatment first, wait, and then give second, some such sequence is all very ongoing research to not increase toxicity, but improve the efficacy.
Thank you. So I think we'll just move on to the...
Okay, so now to the next very interesting treatment, the second, which is the bispecific antibodies. So these are very antibody molecule with a very interesting mechanism of action. So antibodies are supposed to bind to a target. This is how antibodies help treat infections. We can take COVID antibody, and the antibody will go bind COVID virus and make it neutralize it. Here, the antibody is programmed to go and bind myeloma cell. These bispecific antibodies are made special that one end of the antibody binds to myeloma cell, the other end of the antibody binds to the immune cell. And in the process, it brings both together. And when the immune cell comes close to myeloma cell, it kills it. So this antibody brings those together and leads to killing of myeloma cell. Now the target is still BCMA for the first two important bispecific antibody. We call bispecific because it specifically binds to tumor cell, myeloma cell, and the immune cell. So one of the one which is approved now and commercially available is teclistamab. Now, it's given by injection. It needs to be given at least initially once a week infusion. And the response rate is around 65%, 63 to 65%. Again, these are very advanced patients with 5 or more cycles of treatment already received. And in those patients, this is an incredible response. The second bispecific, similar action, everything similar, is elrantamab. That's also now just commercially available. Response rate is same, 2/3 of the patient respond, and its effect lasts for quite a long period of time. So both of these have some advantages over CAR-T cell. CAR-T cell, we have to collect the cell, send it to lab. It takes around 2 months to prepare the CAR-T cell, and then we can give it to the patient. Those 2 months are critical. In many patients, myeloma may not remain in remission. And because of that, we may have to give some other treatment, and sometimes we are not able to successfully control it. The bispecific works similarly through immune cells, and it's in a bottle. It's available as a drug. So we can very easily and very quickly be able to give it. So because of that, there are situations where we prefer bispecific because I can give a patient bispecific in 2 days. CAR-T will take 2 months. So because of those advantages, bispecific have become very important new treatment in myeloma. And this is a laundry list of all different bispecific by all different companies. And the response rate is same, 2/3 to 70% patient respond. And the side effects of bispecifics are milder, but very similar to CAR-T cells. They get cytokine release syndrome, small, very small 1% incidence of neurotoxicity. But infections are important issue, and that's why you need a very good follow-up with the physician to make sure either it is prevented or number 2, it is treated quickly if it occurs. Now, these new treatments, how different are they from the old treatments? Now, the old treatments are not old. Those old, so-called old treatment is what we use quite routinely. If you look at lenalidomide, bortezomib, and other, that's our standard treatment. I just talked about it in the beginning. But when those so-called old drugs were approved, the response rate was 30% or so. And it was good enough for approval. The new treatment, they have significantly higher response, 60 to 90%. So if old treatment achieved what it did so far, you can imagine with double or triple the response, new treatment is going to revolutionize how the myeloma patients are going to do. And I won't go through the details on this very busy slide, but the point I wanted to put across is that even with great success of CAR-T, we are doing a lot of research to improvise, make it easier, more effective, safer, less toxic, etc. And we are changing how CAR-T cells are produced or bispecifics work. We are changing so the target is expressed more on the cell surface, and we are beginning to find what is the right time to treat the patient. As Fredrik said, earlier the better. There is a less heterogeneity, so we treat early, we can get better, longer response. So in this process of doing new things, we have all these new targets that we are beginning to develop CAR-T or bispecific against. BCMA is one, GPRC5D is somewhere here, there it is. That's already in the clinic, and it's going to hopefully be available in 2 to 3 years or sooner. But then there are a lot more, and some are not here. So a lot of hope for new target, variable target. Also, we are beginning to make it differently. So as I said, CAR-T cells takes 2 months to prepare. This particular CAR-T cell that I have on the slide, that my colleague at Dana Farber, Dr. Sperling, is leading that study, it can be produced in 2 days. So we take cells, in 2 days the CAR-T cells are ready. And they are also of a better quality. They are of what we call memory T cell. The cells survive in the body longer, can clean up myeloma better. So this is really a good advancement from that angle. And it works still almost 100% of the time. So very effective, longer lasting. So why do we want it to persist? It's what it works like a maintenance treatment. If CAR-T cell stays in the body for 2 months, 3 months, 6 months, if myeloma cell shows up from some corner in the body, it can still go and kill it. So persistence has some benefits. And then the new target. So this GPRC5D bispecific is already approved in the United States. I think it's going to be approved here in Europe very soon. I think it's not approved yet. But it's a second target, extremely effective. 3/4 of the patient, 73, 74% of the patient respond. And it works also when BCMA CAR-T bispecific may not work. There is a CAR-T also targeting the same target, is in the clinical study, so great excitement for the second target. There is a specific toxicity which is different with this CAR-T cell. It causes skin rashes, it causes some nail problem. And we are beginning to know how best to treat or prevent it. But it's something we take it very seriously and closely. Also, it causes problem with the test. Patients lose taste, not permanently, for a certain period of time. But they're all side effects we can overcome. There's a third CAR T cell with a third target, FcRH5, that's a target. And you don't need to remember the drug's name is cevostamab. Again, works in 58-60% of the patient, different target, similar treatment. So we have already have three targets. More are going to come, so we can begin to use in some succession. And there is this concept that we are all looking at in the clinic, which is what we could call total immunotherapy, where we give the induction treatment. I talked about the 4-drug regimen, that or some such version of it. The newer drug, mezigdomide, might be there. Then we have consolidation with CAR T cell. Transplant is the current consolidation. CAR T cell could be the next one. And then maintenance treatment could be with one of the bispecific or two of the bispecific, etc. And this is the curative strategy for myeloma. Now, this is a very complex scientific slide, and I kept it for a purpose. I don't want you to worry about the Western blots and all the scientific thing. This is for the message of hope, that although we have great success, till the last patient is cured, we still have tasks to do. 10% getting cured or 20 is not enough. So these are newer targets, and I'm just going to show two. But they're very exciting, they're very encouraging leads. Both have been done, work has been done in my institution. This is with my colleague. There's a molecule target called this one. And basically in mice, proportion of mice here are not, myeloma is not coming back when the drug that goes after this target is utilized. So very exciting. And second one is a huge area. We know with the COVID vaccine, we have these RNA-based treatments. And actually the one who developed it got the Nobel Prize for developing RNA-based vaccines. So we have a lot of new interest in going after RNA, what we call long non-coding RNA. We had already determined almost 2018 that there are types of RNA which are important in myeloma. And one such, this is the name for it, has become a good treatment target. And there are 62 of these. So this is the first. We could have 62 more targets. And you can say that within a very short time, all this blue color is myeloma, blue and purple and red. A lot of mice, the myeloma goes away with going after this. So there is great hope and excitement for such new treatment that will become available and utilized over time. So if this is less toxic, that will give the old treatment will give way to some of this treatment. But there are a lot of good scientific advances that are happening in this area. So if we conclude, and then we can discuss, is what is the state of the art in myeloma treatment? The principle is to deliver the best tolerated, most effective treatment as the initial treatment. The old concept that I'm going to keep something for later because if myeloma comes back, what do I do? That's not the right concept. We need to hit the enemy when it is the weakest. If you wait, it's going to get stronger. So the most effective, best treatment starts in the beginning. And we have talked about what those options are if you're transplant eligible or not, or all same. We are beginning to use the bispecific and CAR T earlier on, because that's the best treatment, we need to bring it early. And over time, with all these targets, it's going to come early. And if myeloma comes back, at the early evidence, we should go with the next best treatment and do the same thing. And even then, we can achieve very good response. And our final thing is that we need to bring myeloma to this MRD negative status, which persists. So if you can't detect myeloma, and that state remains for a long time, number one. And number two, we need to normalize the immune system. Myeloma is a disease of immune system. Myeloma patients have a little less immune function. If we normalize the immune function, that's our ultimate goal, and that would be translated to cure in any language. So I think that's where we are heading towards. We're almost there, and it's literally short time before we can come out and say that it's a curable disease. I think we are curing it. We are not yet bold enough to say it. Hopefully very soon we might be able to say it. These are some of my colleagues in the lab who work on all various research topics on genomics and immunotherapy, and they are the ones who really do the work. I go and give the talk. So thank you very much, and these are my other colleagues. Thank you.